So definition of Anasarca. Anasarca is defined as gross generalized edema. So edema represents an excess of interstitial fluid that is evident clinically. Get this out. Not fit. So our total body water is mainly 60% of our body weight. Now out of this, the total body water, 40% is intracellular fluid and 20% is extracellular fluid. So now the extracellular fluid is divided into the interstitial fluid, that is 3/4 of our extracellular fluid, and plasma or the intravascular volume, which is 1/4 of the extracellular fluid. So among the extracellular fluid, interstitial fluid is more than the plasma or intravascular volume. So there is a constant interchange of fluids between these two compartments of the extracellular fluid. That's between the interstitial fluid and the plasma or the intravascular volume. So when the interstitial fluid becomes evident clinically, that is what is known as, and that to generalized, it is generalized body swelling. That is the interstitial fluid that is evident clinically. So there is the stalling forces in the shifting of fluid in the different compartments. First is the hydrostatic pressure within the vascular system and the colloid oncotic pressure in the interstitial fluid. They tend to promote movement of fluid from the vascular to the extravascular space. By contrast, the colloid oncotic pressure contributed by the plasma proteins and the hydrostatic pressure within the interstitial fluid promote movement of fluid from fluid into the vascular compartment. So these are the different pressures operating in the different fluid compartments. These interchanges of fluid are normally balanced so that the volumes of the intravascular and interstitial compartments, they remain constant. However, net movement of fluid from the intravascular to the interstitial spaces takes place and may be responsible for the development of edema under the following conditions. So it is through these mechanisms that Anasarca is evidenced clinically. That is, there can be a decreased plasma oncotic pressure, there can be lymphatic obstruction, there can be an increased capillary permeability, there can be increased intracapillary hydrostatic pressure, there can be an increase in the oncotic pressure in the interstitial space. So through these mechanisms, the fluid gets shifted, there is an increase in the volume of interstitial fluid, and Anasarca is evidenced clinically. So first, there is decreased plasma oncotic pressure. This is due to the depletion of plasma proteins. This occurs in nephrotic syndrome, liver failure, and malnutrition. Then there can be an obstruction of the lymphatic flow. Then there can be increased small vessel permeability due to the increase of chemical mediators. Plasma proteins, they leave the circulation and draw more water in the interstitial spaces. This occurs in allergic reactions like anaphylaxis, asthma, hay fever. Okay, so the plasma proteins, they draw more water into the interstitial spaces. The fourth mechanism, there is increased hydrostatic pressure. This causes more water to be driven outwards in the interstitial spaces. This occurs in congestive heart failure, liver cirrhosis, renal disease. So there is a few mechanisms that play an important role in the development of Anasarca, that helps to keep the fluid balance in the intravascular and extracellular compartments, extravascular compartments. So reduction in the effective arterial volume. So when there is a reduction in the effective arterial volume, that's because the underfilling of the arterial tree could be because of there is a decrease in cardiac output or systemic vascular resistance as well. So by the pooling of blood in the splanchnic veins as in cirrhosis and by hypoalbuminemia. Okay. Renal retention of sodium and therefore water, thereby restoring the effective arterial volume, but sometimes also leading to the development or intensification of edema. Now, the other role, renal factors and the renin, angiotensin, aldosterone system, they have an important role to play too in Anasarca. The diminished renal flow, blood flow is characteristic of states in which the effective arterial blood flow is reduced and is translated by the renal juxtaglomerular cells into a signal for increased renin release. Okay, so then there is the diminished renal perfusion because the effective arterial blood flow is reduced. There is a renin release by the renal juxtaglomerular cells. And angiotensin 2 has generalized vasoconstrictor properties on the renal efferent arterioles. So now this action reduces the hydrostatic pressure in the peritubular capillaries, whereas the increased filtration fraction raises the colloid osmotic pressure in these vessels, thereby enhancing salt and water reabsorption in the proximal convoluted tubule, as well as in the ascending limb of the loop of Henle. The renin angiotensin aldosterone system activation, it causes sodium and water retention and thereby contributes to the edema formation. And thereby aldosterone enhances the sodium reabsorption by the collecting tubule, further favoring edema formation. The next component is the arginine vasopressin, AVP. The secretion of AVP is by the posterior pituitary gland, and arginine vasopressin increases reabsorption of free water in the distal tubules and collecting ducts of the kidneys, thereby increasing the total body water. Circulating arginine vasopressin in many patients with heart failure. Such patients, they fail to show the normal reduction of osmolality, contributing to edema formation and hyponatremia. Okay. Next component is the endothelin 1. So this is a potent peptide vasoconstrictor, which is released by the endothelial cells. Its concentration in the plasma is elevated in patients with severe heart failure and contributes to renal vasoconstriction, sodium retention, and edema. Then coming to natriuretic peptides. Atrial distension causes release into the circulation of ANP. They are stored in the secretory granules within the atrial myocytes. The brain natriuretic peptide BNP is stored primarily in the ventricular myocytes and is released when ventricular diastolic pressure rises. So released atrial natriuretic peptide and the brain natriuretic peptide, they bind to the natriuretic receptor A, which causes 1. Excretion of sodium and water by augmenting the GFR, inhibiting the sodium reabsorption in the proximal tubule, and inhibiting release of renin and aldosterone. Second, it causes dilation of arterioles and venules by antagonizing the vasoconstrictor actions of angiotensin 2, arginine vasopressin, and sympathetic stimulation. Thus, elevated levels of natriuretic peptides have the capacity to oppose sodium retention in hypervolumic and edematous states. This pro-BNP is elevated in heart failure and in cirrhosis with ascites. Not sufficiently, they are not potent to prevent edema formation. Now coming to the causes of Anasarca. So mainly the three main causes is cardiac, renal, and hepatic. So in cardiac, we have the cardiac failure, pericardial effusion, and constrictive pericarditis. And renal, the reasons are the chronic renal failure, nephrotic syndrome, and in hepatic causes is cirrhosis. Then the fourth contribution could be because of malnutrition or malabsorption syndromes like celiac disease or Crohn's disease. Then drug-induced, it can be, and thyroid disorders. All these can cause Anasarca. Clinical features. What do you see? There can be puffiness of face, pedal edema, it can be pitting or non-pitting, abdominal wall edema by pressing with the palm, sacral edema, all these are edema on the dependent portions. Sacral edema, pedal edema. Now coming to cardiac. So the first cause for Anasarca. So usually the patient presents with a history of dyspnea on exertion. It can be associated with orthopnea or PND. Physical examination could be, what do you see on physical examination? Patient might have elevated JVP. There can be a ventricular S3 gallop. There can be a displaced or dyskinetic apical impulse. There can be peripheral cyanosis. There can be cool extremities, a small pulse pressure when severe. There can be basilar rales on examination, as in pulmonary edema. Hepatomegaly can be there as a result of congestive hepatomegaly because of right heart failure. So lab findings will be patients can have elevated natriuretic peptides, that is pro-BNP. There can be cardiac enlargement on X-ray. There can be ventricular hypertrophy, which is found out through echocardiogram or ECG. So the edema of cardiac origin. So what is the special characteristics of edema arising from, or Anasarca arising from cardiac origin, is that it occurs first in the lower extremities and it is symmetrical, it's painless edema, it can be a pitting edema. The presence of a heart disease, that this patient may present with complaints of dyspnea, there can be cardiac enlargement, tender hepatomegaly, there can be elevated jugular venous pressure, which is all suggestive of right heart failure. So now coming to the mechanism through which heart failure. So in heart failure, the patient will be having, in heart failure, there will be an impaired systolic emptying of the ventricles, or there can be an impairment of the ventricular relaxation, which promotes the accumulation of blood in the venous circulation. Okay, so these reasons, they lead to decreased cardiac output. And then in addition to that, there can be activation of the sympathetic nervous system and the renin-angiotensin-aldosterone system. These mechanisms, these systems get activated in concert to cause renal vasoconstriction, and there is reduction in the glomerular filtration rate, and there is salt and water retention. Sodium and water retention, they continue, and the increment in blood volume accumulates in the venous circulation, and thus raising the venous and intracapillary pressure, leading to edema. Okay, so renal and water retention, there is renal sodium retention, all giving rise to edema. Ultimately, there is the restoration of the effective arterial volume. So all these mechanisms, they contribute to maintain the effective arterial volume. Now coming to hepatic cause of Anasarca, usually how the patient presents is that they have dyspnea is very uncommon presentation in these patients, except for ascites. Massive ascites can cause dyspnea. There will be a history of ethanol abuse. In physical examination, they will be frequently associated with ascites. JVP will be normal or low. BP will be lower than in cardiac or renal disease. There can be signs of chronic liver disease like jaundice, palmar erythema, diputerin's contracture, spider angiomata, male gynecomastia, asterixis, encephalopathy. Lab findings, if severe, there will be reductions in severe serum albumin, cholesterol, hepatic proteins like transferrin, fibrinogen, liver enzymes are elevated. There will be a tendency towards hypokalemia. There can be respiratory alkalosis. Alcoholic patients, they have macrocytosis from folate deficiency. So all these will be the lab findings. Now coming to renal, if the patient is having renal, then there will be a history of chronic renal failure, usually chronic. They'll be having uremic signs and symptoms. Dyspnea can be present, but less prominent than in heart failure. These patients have elevated BP. They'll be having hypertensive retinopathy on fundus examination. They can have a nitrogenous fetor, pericardial friction rub. Lab findings, they will have elevation of serum creatinine, albuminuria, hyperkalemia, metabolic acidosis, hyperphosphatemia, hypocalcemia, normocytic, normochromic anemia. All these are complications of chronic renal failure. Then the second reason will be nephrotic syndrome causing Anasarca. Physical examination, usually patient presents with periorbital edema, hypertension, lab finding will be having proteinuria, massive proteinuria of more than 3.5 gram per day, hypoalbuminemia, hypercholesterolemia, microscopic hematuria. All these are findings of nephrotic syndrome. So they'll be having characteristics is mainly because of the salt and water retention. They develop uh, edema in the acute phase of glomerulonephritis owing to renal kidney dysfunction. And as I said, they can be associated with hematuria, hypertension, renal dysfunctions. They have periorbital puffiness. Okay. So now coming to the mechanism, nephrotic syndrome and other hypoalbuminemic state. The primary alteration in nephrotic syndrome is a diminished colloid oncotic pressure due to losses of larger quantities of protein in urine and hypoalbuminemia. As a result of the reduced colloid osmotic pressure, the sodium and water that are retained cannot be confined within the vascular compartment, and total and effective arterial blood volume, it decreases. This process initiates the edema forming sequence of events, including activation of the renin-angiotensin-aldosterone system. This is the typical picture of a patient having nephrotic syndrome. Now coming to cardiac and renal causes of edema. Cardiac, it starts with the legs. It's a very slow progression. They can have signs of heart failure, as I already explained, cardiomegaly, JVP rise, tender hepatomegaly, whereas renal, it starts from the face, periorbital facial puffiness. It's a quick progression with all the findings of proteinuria, hypertension, deranged KFT. In edema of hepatic origin, there can be evidence of spider angiomata, there is the icterus, there can be ascites. Now in hepatic cirrhosis, the mechanism is, the condition is characterized in part by hepatic venous outflow obstruction, expands the splanchnic blood volume and hepatic lymph formation. Intrahepatic hypertension acts as a stimulus for renal sodium retention and causes a reduction in the effective arterial blood volume. These alterations are frequently complicated by hypoalbuminemia secondary to the reduced hepatic synthesis of albumin, as well as peripheral arterial vasodilation. So these effects reduce the effective arterial blood volume, leading to activation of the sodium and water retaining mechanisms. Initially, the excess of interstitial fluid is localized proximal to the congested portal venous system, causing ascites. In later stages, when there is severe hypoalbuminemia, peripheral edema develops, and a sizable accumulation of ascitic fluid may increase in the intra-abdominal pressure and impede venous return from the lower extremities and contribute to the accumulation of edema. Now, there are drugs causing edema. They are the non-steroidal anti-inflammatory drugs, NSAIDs. There is the antihypertensive agents, that is the arterial vasodilators like hydralazine, clonidine, methyl dopa, minoxidil, calcium channel antagonists, alpha adrenergic antagonists, thiazolidinediones, the steroid hormones like glucocorticoids, anabolic steroids, estrogens, progestins, cyclosporin, growth hormone, immunotherapies, interleukin-2, OKT3 monoclonal antibody. So these are drugs, some of the drugs that cause edema. Now, drug-induced edema, the mechanism is renal vasoconstriction caused by NSAIDs and cyclosporin. Vasodilators cause arterial dilation, augmented renal sodium reabsorption by steroid hormones, and capillary damage. These are the mechanisms through which drug-induced edema happens. Now coming to edema of nutritional origin. So a diet grossly deficient in calories and particularly protein over a prolonged period may produce hyperproteinemia and edema. The latter, that is hyperproteinemia, may be intensified by the development of beriberi disease, which also is of nutritional origin, in which multiple peripheral AV fistulae result in reduced effective systemic perfusion and effective arterial blood volume, thereby enhancing edema formation. So edema develops or becomes intensified when famished subjects are first provided with an adequate diet. As I already explained, we covered about the investigations. How we investigate is through serum proteins and albumin, urine analysis. You have to conduct to check the protein, sugar, any caste. Also then kidney function test, that is a KFT, urea and blood urea and serum creatinine. Liver function test, namely the enzymes SGOT, SGPT, alkaline phosphatase, serum bilirubin, then fecal fat estimation to rule out malabsorption, thyroid function tests, then ECG and echocardiography, also the chest x-ray. Okay, so echo will help to find out the left ventricular ejection fraction, any valvular lesions, any regional wall motion abnormalities. So treatment ultimately is by the treatment, finding out the treatment of the underlying cause, whether it's cardiac, renal, hepatic, thyroid abnormality. Stop and replace the drugs causing edema. Can give diuretics, keeping the BP in check. They can have restrict salt and fluid intake, and monitoring the input output, fluid intake and urine output, and a protein-rich diet in hypoalbuminemic state in malnourished patients. Protein energy malnutrition. So with this we come to an end, how to approach a case of Anasarca. Okay.